Welcome to the musculoskeletal physical examination for the hip. In this video, we will demonstrate how to effectively and safely assess the hip joint for signs of musculoskeletal diseases or injuries, with a particular focus on the clinical signs of osteoarthritis. The learning objectives for this video are to demonstrate how to fully examine the hip joint using the look, feel, move and measure method, to show the most relevant anatomic landmarks of the hip, and lastly, to develop a consistent pattern for examining the hip. It is the assumption that a detailed medical history has already been taken with the patient. Prior to starting the examination, wash your hands, introduce yourself, and explain the examination procedure. Ask if they have any questions about the assessment. If they do, explain the examination thoroughly. If they do not have any questions, ask if the patient is happy for you to start the physical examination of their hip. When you're ready to start, ask that the patient stand up and ensure that you have adequate exposure of the area being assessed. When assessing the hip, it's preferable that the person is barefoot and wearing a pair of shorts, so the hip, the leg, the knee, foot and ankle can be easily viewed. Ask that the patient start walking as they normally would. Make sure there's enough space for 10 to 12 steps and that they walk back towards you. As the patient continues walking, you should be examining their gait pattern. First, have a general inspection of their gait pattern. Look for the gait speed, symmetry, and stride length. Once you've had a general look and inspection, move on to a more specific look at the system. Observe the movement at the pelvis, knee, and ankle joints. Check for any signs of abnormal movement at these joints and how they might affect the hip joint. It is easier if you develop a system. For instance, look at the joints from a proximal to distal manner. Is the pelvis symmetrically aligned during the gait cycle? In sequence, inspect how the hips, knees, ankles, and feet move throughout the gait cycle. Remember, you're looking for symmetry from side to side and the presence of any signs of abnormality, such as, is there too much pelvic tilt? Do the hip and knee move freely from flexion to extension throughout the gait cycle? Is there an exaggerated amount of foot pronation? We will now move on to inspecting the patient's hip and lower limb. With the patient facing forward and then sideways, inspect the following. Muscle atrophy. Look for differences in muscle bulk between the limbs, especially the gluteal, hamstring, quadriceps, and adductor muscle groups. Hip alignment and deformity. Look for any deformity, including leg length discrepancy, and check the alignment of the hips, ensuring they appear symmetrical. Assess posture. Assess the overall posture, making any note of any abnormalities in the alignment of the spine, hips, and pelvis. Discoloration. Examine the skin for any abnormal discoloration, such as bruising or abnormal pigmentation. Assess for swelling. Look for any signs of swelling or edema in the hip or lower limb area. Check for scarring. Check for any visible scars, surgical or otherwise, in the hip or lower limb region. Check for bleeding. Look for any signs of active bleeding, open wounds or discharge. Compare bilaterally. Compare the left and right hips and lower limbs, looking for any differences in muscle size, alignment, or other abnormalities. Repeat above steps of inspection, looking at the patient from the lateral aspect, focusing on the hip and lower limb of both right and left sides. Now move on to the feel phase of the assessment. Palpate skin temperature and feel for any signs of heat, swelling, or inflammation. Palpate the ASIS bilaterally, checking for signs of pain or point tenderness. Palpate over the greater trochanter and trochanteric bursae, again bilaterally, checking for any signs of pain or point tenderness. Palpation of the pubic symphysis, checking for signs of pain or point tenderness. Palpation of the ischial tuberosity and sacroiliac joints bilaterally, again, checking for signs of pain or point tenderness. Palpation of the PSIS bilaterally, checking for signs of pain or point tenderness. Palpation of the ischial tuberosity and sacroiliac joints bilaterally again, checking for signs of pain or point tenderness. We begin with the examination of the hip flexion extension. Ask the patient to bend their knee and bring it towards their chest into flexion. Observe and estimate the range of motion in degrees. Compare the range of motion bilaterally. Next, ask the patient to straighten their leg. Extension is usually able to go beyond neutral, so if you detect any abnormality, ask the patient to lie prone and examine them in that position. The examiner then completes this movement passively to compare the passive range of motion. Continue with the examination of the hip, adduction and abduction. Ask the patient to slide their legs sideways towards the midline of the body to assess the active adduction range of motion. The examiner then completes this movement passively to compare the passive range of motion. Then ask the patient to slide their legs sideways away from the midline to assess the active abduction range of motion. The examiner then completes this movement passively while ensuring the pelvis is not moving to ensure this range of motion is limited to the examination of the hip to compare the passive range of motion. Now perform the examination of internal and external rotation of the hip. Bring the patient's hip and knee into 90 degrees of flexion. Rotate the hip inward, internal rotation, by moving the patient's ankle away from the opposite hip. Ask if this movement is painful. Limited internal rotation with pain are cardinal clinical features of hip osteoarthritis. Next, rotate the hip outward, external rotation, by moving the patient's ankle towards the opposite hip. Assess for symmetry, observe, estimate, and compare the range of motion bilaterally. After assessing the movements of the hip joint, we will examine the integrity of the structures around the hip joint. For the Trendelenburg test, the examiner asks the patient to stand on one leg while the examiner observes their pelvis position from behind. The patient stands on their left leg first. The examiner then asks the patient to raise the right leg off the ground. The examiner asks the patient to keep that position for a few seconds while observing the position of the PSIS, the dimple in the small of their back. The examiner is looking for any drop or tilt of the pelvis on the unsupported side. This test assesses the strength and stability of the hip abductor muscles, primarily the gluteus medius. This test is then repeated on the contralateral side for comparison. Next, we will perform Ober's test to assess for contracture of the patient's iliotibial band. The patient is lying on their side with their bottom knee bent for support. The examiner then brings the top hip and knee to 90 degrees of flexion. The examiner then passively extends the patient's top hip while keeping the knee bent. We're looking for any restriction or pain on the outside of your hip. This test helps us to identify iliotibial band or tensor fascia lata tightness or contracture. Now we'll assess for flexion contracture using the Thomas test. The patient is lying supine or on their back. The examiner places one hand under the small of the back and the other on the knee. The knee and hip are flexed passively until the back is flat on the bed. If the contralateral leg raises off the bed, this indicates a limitation of hip extension or a fixed flexion contracture. This test helps us to identify restricted hip extension range of motion or contraction of the psoas and hip flexor muscles. Next, we will evaluate for true and apparent leg length discrepancies. First, we assess for true leg length discrepancy. Using a tape measure, the examiner measures from the anterior superior iliac spine to the medial malleolus. This is compared bilaterally. Next, compare the measurements from the anterior superior iliac spine to the superior patella. This will assess anatomical or true leg length discrepancy. To find the true leg length difference, we subtract the ASIS to medial malleolus measurements of the shorter from the measurement of the longer leg. Lastly, we will assess for apparent leg length. Apparent leg length discrepancy can be caused by factors such as pelvic tilt or spinal curvature. The examiner measures the distance from the umbilicus to the median malleolus and then completes the same on the other side, comparing bilaterally. This measurement considers any alterations in leg length due to factors other than bone length. So that's done for the examination, all done. We can get you to sit up.